session, so we go
We have
back to the
bilateral
order.
cataract surgery after myopic lenticular extraction in megalocornea, right? Yes. Cyres had
Has got some of the high court. So, what is my 62?
Below.
Thank you.
Yeah, that.
Today about in megalocornea. Worldwide find any slit lamp showed bilateral megalocornea with distance of 14.8, clear cornea, pachymetry of 413, otherwise the eye being normal. And no published report of refractive surgery in megalocornea done worldwide. This is the first case which I believe we had done. This is the pictures as it shows in the top left hand side, the original topography. The middle shows you the thickness, which is 413 and 410. Measuring the calipers at the side, we did a smile. Maximum capacity 7.5, and this was the result which we got subsequently. He was now comes 2024, life was fine. At that time he was only a lawyer. Now he is the assistant public prosecutor by profession, which makes once again the poor doctor now run. He is 6'12", 6'9", he can't manage in the court, and he comes and says he wants to be spectacle free. We explained to him that no one has done it before, and the uncertainty of IOL power, he was willing to take the risks and decided to go ahead. Still, we ran it through the ethics committee to be on the safe side, and we targeted at minus 0.75. We did an IOL power calculation, showed it to be 15 and 18, as you can see from the side. We tried to do a FLAC utilizing the catalyst. However, it refused to accept the curvature. I'll demonstrate it to you in a moment. Had to do a regular routine procedure. Subsequently, we implanted a Rayner lens. The details are at the bottom. This is a short video of the procedure, how it was done. Essentially, you can shut the sound. First, the smile was done in 2019, and then subsequently in 24, the patient returned with a cataract. Flax was attempted. Is unfortunately on a megalocornea, it does not accept it. As you noticed, despite the multiple trials, refused to accept it. It just does not fit. And we then had to do it by a routine. We did our rexus manually and subsequently bisecting the cataract, and we implanted a Rayner lens in the eye. Prior to that, to stabilize the bag, because these are enlarged bags, we put in a capsule attention ring, because it's well known with megalocornea, you tend to get an occasional subluxation. And we put in an EDOF lens, which is the Rayner EDOF lens, which we put. The reason we chose an EDOF Rayner lens is because this is a 12.8 millimeter diameter lens, and it's nice and wide and big, and Rayner lenses are very stable. And as you noticed in the last measurement which was taken, it is 14.8 is the diameter of the cornea. So, bilaterally, 2 days post-procedure, 1 year follow-up, stabilized. IOL power calculation was challenging as no formula was available. But the surgery at the IOL is big enough. We have utilized a Barrett's formula, which has proved to be fairly accurate. IOL has to be big enough to fit this eye. The maximum we could get was the Rayner, which literally worked out well. We put in a capsule tension ring from ring inject from Optec, which is a very soft ring and enables you to get along well enough. In conclusion, it was a bilateral cataract surgery with EDOF post-smile, a unique approach which is there. These are the references we got, including our publication in the Indian Journal of Ophthalmology. Thank you very much for your kind attention.
Thank you, Dr. Keiki. Nice presentation. But since we do expect capsular instability in these eyes, you put a CTR. But could you have gone a step forward and done a reverse optic capture kind of situation? One question. Second question, with the possibility of a capsular instability on the table or later on happening too, was it wise to place an EDOF lens, that too in a post-refractive surgery?
No, we wanted a Rayner lens. Now, Rayner toric only comes in EDOF. It was not an option we exercised. Rayner torics don't come in a non-EDOF style, so we have put in EDOF. Now, between you and me, I don't know whether EDOF lenses really work. I mean, I know they have got a big lineup. I am basically a trifocal surgeon, and in my opinion, EDOFs work good for intermediate. EDOF was started when? It was started in Europe because people had wanted to see the cockpit of their cars, the dials of the car. They were unable to see it. There were accidents, and in Europe they made it mandatory that if you don't put in an EDOF lens or a trifocal lens, give in writing as to why you have not done it. So this has become common in Europe, and that's one of the reasons why EDOF lenses came into play. But barring that, nothing else.
Okay. Thank you.
Thank you so much
Thank you.
for accommodating me. I'll just run back to my course.
Thank you. Thank you.